I think large cell lymphoma is well known to this group. It's the most common form of lymphoma. You see the characteristic pathology. Obviously, the goal is to cure these patients. Across the board, we cure somewhere around 2/3 of patients with diffuse large B-cell lymphoma. And the diagnosis is obviously made on pathology and the characteristic immunophenotyping, as well as FISH testing, immunohistochemistry testing for the elements as noted, in order to try to characterize the subtype of lymphoma and perhaps the prognostic features of an individual patient's situation. So I think it's important for any talk in large cell lymphoma to keep in mind the International Prognostic Index. We get all caught up and excited about the sexy gene expression profiling and the marker of the day, but the reality is that the IPI has been around now for over 25 years and is the most robust way to prognosticate. I sat in my clinic seeing a patient this week and told him his IPI score. Unfortunately, I didn't have any way to use his IPI score to treat him any differently. And so I think it's sobering that we can have a prognostic score that is so robust and yet very little way where that can measurably impact a patient's outcome by changing treatment. So I think this group likely knows that the general large cell lymphoma standard of care is R-CHOP 21. And what you see in front of you are studies in older patients, younger patients, in various forms, all showing on the left progression-free survival and on the right overall survival, with the addition of rituximab to CHOP chemotherapy. And so the idea that we can improve upon this, because you see that there's obviously room to go as far as curing more patients, I think it's fair to say has been pretty elusive. And so the focus of the rest of this talk is really to talk about the ways that we've tried to improve this, where we have not had success, and where we've maybe had a little bit of success in moving forward, as well as certain subtypes where, if you're seeing these patients, you may want to use something differently. So unfortunately, there have been a number of negative studies. I've been a part of a few of these, as have others in the room. And I think it's fair to say that as of today, adding bortezomib, consolidating with auto transplant, using dose-adjusted R-EPOCH, or adding ibrutinib or lenalidomide really has not been compelling, or in fact been stone-cold negative in trying to improve upon R-CHOP for subsets of patients. So I'm going to just give you some of the information that's at least thought-provoking on a couple of these approaches. I'm not going to talk about the first two, but because particularly the latter two are relatively new, it's worth noting and perhaps a little clear-cut. And then the dose-adjusted R-EPOCH still is potentially used in a couple of situations that I'll get into. So first, the Alliance CLGB 50303 study published by Nancy Bartlett in JCO earlier this year, randomized patients to R-CHOP versus R-EPOCH. As you know, R-EPOCH is an infusional regimen that is more complicated, has more toxicity, and the idea was that this could improve efficacy based on the different dosing pattern and the addition of etoposide. Unfortunately, kind of across the board, looking at all comers, while there's some nuances to this, I think it's fair to say that there's no clear evidence of improvement in event-free survival or overall survival through the use of dose-adjusted R-EPOCH. So we'll come back to this a little later in a few subsets where maybe there's a hint that this could be useful, but I think we really don't have any definitive information at this point that using the dose-adjusted R-EPOCH regimen is worth the hassle or the toxicity for the vast majority of patients. So obviously, the world of large cell lymphoma, again, being humbled, going back to the IPI, been around for 25 years. Now the identification of germinal center or activated B-cell subtype now been around for over 15 years. That got everyone very excited about the idea of subsetting large cell lymphoma into different entities and treating patients differently based on the fact that the germinal center subtype has a much more favorable outcome in these retrospective studies compared to the activated B-cell subtype. And so the concept that there are a number of different targets, some of which you've heard over the course of this meeting, whether it's BCL2 translocations, EZH2 mutations as an example of agents or areas that we could target in the germinal center subset versus a variety of different mutations such as the B-cell receptor signaling and other NF-kappa B, other pathways that could be targeted in the ABC subtype. And so the pattern, as you well know, is to try to take one of these subsets and add into R-CHOP a drug that could be preferentially active or relevant within a subset, in particular the ABC subset, where the prognosis is less favorable with R-CHOP, generally speaking. And so over the last year, we've had a couple of examples of these attempts, which I think are very important and admirable attempts, but albeit unsuccessful attempts. This is the Phoenix trial led by Anas Yunus, published in JCO early this year, adding ibrutinib, which has potential activity in the ABC subtype. This looked at non-GCB subtype as established by IHC, advanced stage disease, primarily patients, looking at event-free survival as the primary endpoint and other standard parameters. You see that the primary endpoint of this study was event-free survival, and whether you look at the intent to treat based on non-GCB or the ABC subset, you see really no difference in the entire population when you add ibrutinib to R-CHOP. There was also more toxicity with ibrutinib, as you would expect when added to R-CHOP. However, there was this glimmer of interest that in the younger patients, perhaps ibrutinib added some value. This can be interpreted in a number of different ways. Some would speculate, and there was some data presented, that there was more toxicity in the older patients, and younger patients were able to tolerate the ibrutinib better, and that allowed them to reap the benefits. On the other hand, these cutoffs were somewhat retrospectively defined, and there are a number of different explanations why this isn't quite robust, mostly the limitations of retrospective subset analysis, retrospectively defined subset analyses. So I think this remains an open question. Some people are still pursuing this. We are looking at ibrutinib in the alliance with the transplant group, looking at ibrutinib in the non-GCB subset in relapsed large cell lymphoma, but I would say that as of today, there's really not good evidence that the addition of ibrutinib should be incorporated into R-CHOP therapy based on the overall negative results of this study. The other area that's been of interest is lenalidomide, which has also had activity in the non-GCB subtype. There were 2 studies presented at the Lugano meeting. Some of you may have seen these, others didn't, and I don't think they've been published yet, if I'm not mistaken. The first was a randomized phase 2 trial, ECOG-SWOG and Alliance, taking large cell lymphoma patients, randomizing them to R-CHOP for 6 cycles or R-CHOP with lenalidomide or R-squared CHOP, looking at and then stratifying and looking at the patients by nanostring and immunohistochemistry to look at the subset that were non-GCB. The primary endpoint was in all patients with large cell lymphoma with a co-primary endpoint of the ABC subtype as defined by nanostring. You can see some of the statistical assumptions there. These results were quite interesting in that R-squared CHOP appeared better in efficacy with regard to progression-free survival, whether you look at all patients or you look at the ABC subtype as determined by nanostring. You see some of the numbers there. So this was exciting. Again, remembering that this was a randomized phase 2 trial. Kind of in parallel and presented at the same session at Lugano was the robust study. This was a larger phase 3 trial looking at untreated large cell lymphoma patients, 570 patients, focusing on the subset, the ABC subset, again, as identified, looked at by nanostring. Only the ABC subset were randomized here, and again, you see R-squared CHOP versus placebo with the stratifications as noted. Unfortunately, in this trial, the more robust phase 3 trial, focusing again on the ABC subtype, no difference between R-squared CHOP and placebo R-CHOP, and so kind of taking the wind out of the sails of adding lenalidomide to R-CHOP-based therapy. So what are the explanations, or what are the potential explanations for these confounding results, or why do these drugs, ibrutinib, lenalidomide, not add anything here? Well, you see a comparison of the 2 studies, and again, there were differences in the identification of the subset, the number of patients, location of the patients. I think two big factors, the dosing and schedule of lenalidomide differed in the trial, so to the extent that that makes a difference. And then I think this bottom feature, which we've learned more and more, is the diagnosis to treatment interval being about a month versus 22 days in the positive trial. And the concept that we've learned more and more about in large cell lymphoma in all of the studies in upfront disease that have been reported in the last couple of years is that diagnosis to treatment correlates with outcome, that studies that have processes that take a long time or that are limited one reason or another to patients that can wait around to go on the study tend to exclude, perhaps inadvertently, less favorable patients, the ones that can benefit from the intervention, and therefore the control arm does better because the less favorable patients are not entering the study. So this is clearly an issue in large cell lymphoma. Whether or not that has to do with why this discrepancy occurred between these trials is uncertain, but certainly these, again, are not compelling for the addition at this point of lenalidomide to R-CHOP based on this package of data. The other aspect of this has gotten very more complicated is the fact that the genetics and pathogenesis of large cell lymphoma has been further elucidated, and instead of this germinal center and ABC subtype, we have a couple of studies, one by Lou Stout's group, one by Margaret Shipp's group, where we have additional subsets of large cell lymphoma where these mutations or these pathways may be more specifically restricted to, and therefore really the effects of these additional interventions are getting diluted out by a patient population that is actually only narrowly potentially impacted by these pathways and interventions. And so you see that we now have a more complicated subsetting and perhaps a more specific subset for these targets to be explored further. And so how we will take this further in this slicing and dicing of the DLBCL population in a precision sort of approach, I think makes a lot of sense, but also has a lot of practical challenges in how you actually get studies done to test these hypotheses and these interventions in these subsets of patients. So with that, for most patients, we're still on R-CHOP on a 21-day cycle as a standard therapy. But for the rest of my remarks, I just want to comment on several other scenarios where perhaps R-CHOP times 6 is not the best treatment, recognizing that the randomized data supporting any of the things I'm going to talk about are relatively limited, except for one or two specific cases. So the first is in limited stage large cell lymphoma. We go back to the SWOG 8736 study showing comparability between CHOP times 3 and evolved field radiation and CHOP times 8. So there have been a number of efforts to refine the therapy of limited stage large cell lymphoma. This is the S0014, looking at R-CHOP for 3 cycles, plus involved field radiation. Again, quite good outcomes here. So the question has then been, well, do you need the radiation? Can we use a PET-adapted approach? We have some data from the BC Cancer Group. Laurie Sen has reported on data looking at R-CHOP for 3 cycles, and then based on the PET, either giving one more cycle of R-CHOP or giving involved field radiation. And I think this has in practice become adopted by a number of groups, particularly in the PET negative group, where outcomes are good if patients are PET negative. That has been looked at in a, I would say, a prospective way and a bigger way as well at the ASH meeting last year. The FLIER study took generally favorable patients, age-adjusted IPI 0 patients without bulky disease, randomized them to R-CHOP for 6 cycles versus R-CHOP for 4 cycles, plus a little extra rituximab, of course. It kind of finds its way into these studies. And the net is that with 4 cycles of R-CHOP, and this was not PET-adapted, that patients did quite well. And so I think more and more we're moving toward the use of or lack of use of involved field radiation in patients with limited stage large cell lymphoma. And we will see presented at ASH the S1001 study. Daniel Persky's presenting. I know this is a little small to see. I apologize. But it's R-CHOP times 3 cycles. The PET negative patients getting 1 cycle more of R-CHOP. The PET positive patients with a less favorable prognosis getting an intensified treatment with radiation and radioimmunotherapy consolidation being PET positive in order to consolidate them. So those data will be presented later this year. So another big area that's getting a lot of attention in large cell lymphoma is the double hit versus the double protein. There are a lot of data on these entities, the double hit being expressing or having translocations of MYC along with BCL2, BCL6, or both. These are typically of the germinal center subtype and do very poor with standard therapies. The double expressing proteins are expressors, not translocated, but expressors of MYC and BCL2. These tend to be in the ABC subtype and are kind of intermediate in their prognosis. Here's these entities are kind of a Venn diagram, as you can see, with the ABC group, ABC subset owning more of the double expressors, the GCB subset owning more of the translocated patients, and particularly the double hits. And so how to take this forward? Well, the data suggests from a variety of different series, this is one, that show that the double hit patients do quite poorly. The double expressors have an intermediate outcome. There are a lot of nuances to this, but this is the bottom line. And so the question is, how should we treat these patients? The double expressors seem to not benefit from dose-adjusted R-EPOCH based on the Alliance data at this point, at least to the extent that we can look at this. There are a variety of studies suggesting that the dose-adjusted R-EPOCH regimen can have benefit, not in comparative randomized trials, but can have benefit in a double-hit lymphoma subtype. And I think most people would argue that the double-hit patients should be treated more aggressively, and I would say most commonly dose-adjusted R-EPOCH seems to be what is used. I will mention that the Alliance is leading a recently activated study in double-hit and double expressor patients, led by Jeremy Abramson, where patients are randomized to R chemotherapy, either R-CHOP if they're double expressors, or R-EPOCH if they're double hit, with or without venetoclax, the inhibitor BCL2. So that study is just activated, and I would encourage you, if you're a cooperative group participant, to explore participation in that trial that will see if the addition of venetoclax can improve chemoimmunotherapy in these patients. I just want to wrap up with a couple of points around CNS progression. This is, I think, in meetings like this, whenever people present cases or have questions, do you prophylax? Who's at risk for CNS involvement? And I think this is probably the closest to the state of the art of who is likely to have CNS, or more likely, I should say, to have CNS involvement. We have the CNS IPI, and one of the factors is kidney or adrenal gland involvement, as well as age, and then LDH, advanced or impaired performance status, advanced disease. All of these correlate with outcome, but again, these are generally high IPI risk patients, and then there's a kidney and adrenal gland involvement, and you can see that this can lead to up to about a 15% risk of CNS involvement. The question of how you prevent this or deal with this, I think, is an open question. Whether intrathecal chemotherapy prophylactically makes a difference is, I think, open to debate. Certainly, these are patients you might screen more carefully and evaluate their CSF for this possibility. I think many of us have adopted this regimen that Jeremy Abramson has reported on, a series retrospectively of giving day 14 methotrexate, 3.5 grams for a couple of cycles. On day 15 of the R-CHOP cycle, obviously there's not a randomized trial, but in relatively high-risk patients had relatively good outcomes with regard to CNS relapse rate. And I think this has become a generally well-tolerated approach for this patient population that many centers, including ours, have commonly adapted. I just want to end with dose-adjusted R-EPOCH and primary mediastinal lymphoma, and this is a series from my colleague Lisa Roth, who looked at retrospective data from a number of centers suggesting that dose-adjusted R-EPOCH, this was based on the NCI data, had quite good event-free survival in patients, whether they were adult or pediatrics, and that the PET scan, particularly if you were DOVA 1 through 3, and even so, DOVA 4 could have good outcomes. These patients, some of which were radiated, most were not. And the intergroup is now looking at a checkpoint inhibitor in combination with dose-adjusted R-EPOCH in this patient population, checkpoint inhibitors being approved in relapse primary mediastinal disease. Finally, the other scenario where something else might be used, our mini-CHOP has accumulated substantial data in patients over the age of 80. This attenuates doses of cyclophosphamide, doxorubicin, and vincristine, as you see. And the data with this approach, depending on your performance status and IADL score, is associated in patients over the age of 80 with a fairly reasonable outcome. And so this has become, I think, the default standard. The intergroup led by SWOG is advancing a study looking at R-mini-CHOP with or without azacitidine as a hypomethylating agent to see if that can improve the efficacy of R-mini-CHOP based on data from Leandro Cerchetti, who was here this morning. And I think this is an interesting study that if you see older patients with large cell lymphoma, maybe one that you want to consider opening at your center. So with that, I will thank you very much for your attention, and we'll talk more later in the question session. Thank you.